Welcome to Health IQ. I'm Dr. Alan Siegel. Today we have a returning guest, Dr. Stuart Elkowitz from NYU Langone. He's an orthopedic specializing in the upper extremity. Welcome back, Dr. Stu.
Thank you. Great to be here. It's been an interesting year.
Yes, it has been an interesting year. So let's talk about medicine in this year and how things are going, especially as an orthopedic, where typically you find yourself in an operating room, and we all know from the pandemic, things were shut down. And what has changed not only for yourself as a practitioner, but for the patients that you've seen?
Sure. Yeah, there was a period where we were shut down for about 6 weeks, not allowed to operate. So as physicians, we all pitched in and did our role in taking care of patients that were affected. But once we got back up and running, there definitely were some changes in the way we were seeing patients, particularly with telemedicine. This was a great opportunity to really have that technology explode and take care of patients remotely. We are still doing it, even though things have been returning to normal. And it is appropriate for many situations, but not all, because nothing can fully replace the hands-on exam. And being an orthopedist, we often need to get an x-ray, which often requires an in-person visit. But we've used it a lot for our post-operative patients where we just need to be able to visualize their motion, see if those are the ones that need to go to therapy or not, check wounds. It's great when patients have questions, they're concerned that the wound isn't healing appropriately, and we can do a face-to-face visit. We do use it for new patients as well. Some people just need a little peace of mind. They just want to know what are some early things that they can try. And if someone, says, I think I have some carpal tunnel, a lot of times that can be based on some provocative maneuvers or just taking a detailed history. And if it's early on, I can make recommendations, about splinting, positional modifications, ergonomic changes that they can do. And then if those things do not work, then they can come in.
Speaking of ergonomics, with more people working from home and being on the computers and changing their whole pretty much daily routines, have you noticed an increase in different types of conditions that you maybe weren't seeing as much of prior to the pandemic?
There's been a ton of people coming in because their home workstation was set up on the fly during the pandemic and did not have a lot of the ergonomic options that they do at their work, where work often can provide some of those enhanced gadgets. So yes, a lot of people, they come in, they're doing work on their bed, they have their knees up, their elbows bent up with their tablets, their neck is looking down, and even just their own home, they're doing it at the kitchen table. The table is not the appropriate height for a keyboard. So I see a lot of increase in ulnar nerve issues. And ulnar nerve would be defined as numbness in the ring and the small finger, right. Sometimes hand weakness. So you would show where they would feel that, or where that nerve would be more on the inside of the arm? Right. Yeah. So the ulnar nerve is considered also cubital tunnel, not to be confused with carpal tunnel. Cubital refers to the elbow. And as I said, those symptoms are more numbness and tingling in the ring and the small finger. And the ulnar nerve does not like to have the elbow bent more than 90 degrees for any lengthy period of time. So you could see it with people if they're on the phone for too long. So I often say transition to Bluetooth or a headset. But if they're reading and they're bringing it too close, so their elbows are bent more than 90, or their tablet is too close, or even if you're just working at a table where the table is too high or your chair is too low, you will now be bent more than 90 degrees. So I've seen a lot of increase in that. Carpal tunnel, probably not as much, but definitely an increase compared to pre-pandemic, with people doing things more remotely. I think it's important to explain to our viewers that a lot of times you can have feelings and sensations in your hands that may be coming as a hand or lower extremity or upper extremity issue versus possibly a neck issue. And I think seeing a doctor to differentiate those diagnoses for them is important, because they say, well, I have numbness in my hand, or I have pain down the side of my arm, or I have this or that, but it could be coming from other areas. Right, yeah. A lot of people, whether it's via telemedicine or in person, they say, I think I have carpal tunnel. And then carpal tunnel is a very specific set of symptoms. It's numbness, tingling on the palm side of your thumb, index, and middle fingers. It's pain into those fingers that awaken you at night from sleep. And sometimes it can go up the arm as well. But sometimes I'll probe further into patients and ask them, so where's your actual numbness? And they say, oh, it's on the back of my hand. And as you know from your field, numbness on the back of your thumb, back of the index finger, could be more often the C6 nerve root, which is the most common level to get nerve irritation. And I've seen a lot of that as well in the pandemic because working from home, people's monitors, might not be at the correct height. They could be looking down for too long or have their neck hyperextended for too long, and that would exacerbate those symptoms going down the arm.
Yeah, so I think that differential diagnosis is really important, and there's so many things that can go wrong. Now, I assume you noticed probably a decrease in trauma over that COVID, mainstay because people are traveling less. I mean, maybe at some point they were trying to get outside and do more exercise. So I'm sure there's some you deal with bike injuries all the time, I'm sure, and especially aggressive bikers that are constantly like having their hands on these forward wheels and everything. So
yeah, there definitely was a decrease in the number of traumas, or just a shift into the type of trauma that we saw. Obviously people weren't outside playing sports as much this summer. During the winter, people stayed in the house. There was a little dip in terms of the number of wrist fractures we would see from slipping on the ice, just because people were staying from home. But you see more cooking injuries, people cutting themselves in the kitchen because they're preparing more meals from home.
Yeah.
And cutting avocados has become a little bit of a pandemic in and of itself, with people slicing their finger after cutting avocados.
Gotta try something new at home, right?
Exactly. Yeah. So we've definitely seen a spike in that. But we're definitely seeing things start to return to normal now in terms of the number of patients that are comfortable coming into the office. We're seeing an uptick in injuries and jammed fingers from kids returning to sports, people playing pickup basketball. So yeah, things are starting to come back now.
Yeah. Now, in terms of like tendon issues versus bone or joint issues, do you tend to work with both of those types of problems? Because sometimes there's, like you say, like a laceration or someone that gets like a bad cut through their wrist. There's so many fine tendons and nerves in there, and sometimes that'll coordinate. Sometimes even plastic surgeons will do that type of work, depending on the nature of the injury.
Right.
So.
Yeah, no, I take care of all nerves, tendons, bones, ligaments,
okay.
As relates to the hand, whether it's degenerative and it's arthritic conditions, whether it's traumatic injuries, whether it's overuse injuries. We see, in terms of ligamentous injuries, there's definitely been some increase in technology in terms of augmenting our ligament repairs now with something called an internal brace. This gained a lot of popularity a few years ago when Drew Brees.
What type of ligament injury? What would that be described as?
So it could be a ligament injury in your thumb, often known as skier's thumb, from falling. You could have a
painful,
ligament.
I assume, somewhat painful.
Absolutely, absolutely. And you could also, have ligamentous injuries in the wrist. The most common being the scapholunate ligament. So some of this newer technology with internal bracing got a lot of press after Drew Brees smacked his thumb on someone's helmet and tore that ligament. And it augments the repair of the ligament with a suture construct and allows a little bit earlier return to play in these professional athletes. And we are slowly adapting those things, to the general population. A lot of times with the money at stake with players' contracts and their need to get back quicker, sometimes they're willing to embrace technologies a little bit earlier if it can get them back that much faster.
Sure.
And once we have success at that level, then we start to extrapolate that to the general population and start offering them.
And the research has been good on it. The outcomes have been pretty well documented on those. Yeah,
absolutely. A lot of times when we adopt a new technology, we want to first make sure that there's no detrimental effects.
Right.
And that's what we see first, and then we start to notice a lot of the improvements in terms of quicker return to aggressive activities.
Yeah, I think with all medicine, we're living through a pandemic now, something that we didn't all expect to experience. we see how the medical world and the biopharmaceutical worlds can work and how quick and how advanced they can be. Hopefully, obviously, for the betterment of all of us. So it's been interesting. And then technology, when it comes to like orthopedics and like joint regeneration and stem cell, just to throw that term out there,
right,
tends to be a very, very, very slow process because these things are studied over years and multiple double-blind studies to see what the effects are. Unlike the vaccine that we just all took,
right,
which was released and studied over 6 months, but these joint issues and things for joints and musculoskeletal and regenerative health and regenerative medicine tend to take quite some time.
Yeah, biologics is a hot topic at all of our meetings. I think a lot of the advancements in biologic has been more centered around the knees and shoulders. There have been some smaller reports in the literature trying to use PRP in the hand or blood patches around ligament injuries. The problem is sometimes if it's a ligament injury within the joint itself, sometimes the fluid within the joint does not allow the clot to kind of stay there in its native form, as opposed to a ligament that's kind of outside of the joint. So in the hand, we have not been using too much in the way of PRP, except for like tennis elbow or golfer's elbow.
What about like the OA of this joint here? Sometimes this joint gets a little nasty for some people.
Right, so like,
osteoarthritis for
yes.
those that don't.
So what you were just pointing to is the thumb CMC joint, also known as the basal joint. It's the second most common joint in the hand to get arthritis, but it's the most common joint to bring people into the office just because of all the things that we do with our thumb. Studies at the current time.
What's the first joint?
So yes, the most common joint are the joints at the tip of your finger, which are known as the DIP joint.
Right.
And people may often notice little bumps there, and those are just sometimes arthritic bone spurs. But for the base of the thumb, there have been some studies looking at the role of glucosamine chondroitin sulfate injections. It's not FDA approved for those small joints. And some of the longer-term studies show that it's no better long-term than corticosteroid injections.
Has there been any studies on replacement of a joint in the hand, or it's not necessary?
It would be nice, but because of all the planes of motion that are required for the thumb, it doesn't have necessarily the same bony inherent stability like a knee would. Right. So previous attempts at fancy replacements with polyethylene, which is a plastic, and the metal that we do for hips and knees, they have not really withstood the test of time or had the longevity. So at the current time, the operations that we're doing for arthritis at the base of the thumb still involve removing a bone and using predominantly our native tissue, a local tendon, to stabilize the joint. And it's a great operation for pain relief. It's a great operation for preserving motion. Grip strength, usually the most variable outcome. I usually tell my patients, if your grip is so bad preoperatively that it's mitigated by your pain, the grip strength will get better after the surgery because your pain will be gone. But it does not go back to the strength of a pre-arthritic hand. Yeah. And then going back to where these biologics can be useful, tennis elbow, there has been shown to be promise in that. As well as for golfer's elbow. So tennis elbow would be a degenerative process of a tendon on the outer bump on your elbow. Golfer's elbow would be on the inner bump on your elbow. And these are degenerative processes. The literature would support that these conditions can burn out on their own without any treatment, but it can take 1.5 to 2 years for that to occur. Now, most people are not that patient.
And there's surely different severity levels of these issues.
Absolutely.
We've seen patients where, even with conservative therapies and just trying to tell them to rest it and do the right thing, sometimes shaving can be painful. That's how bad it can be for some people.
Right.
It's not always that case, but it can be that bad. So, but some of them will resolve on their own. Majority probably would. But then you have some cases where we finally did an MRI on that particular patient, and he had like a full-blown tendon tear, and he needed surgery. So there was no getting around it.
Right. Yeah. In tennis elbow, people come in all the time. Oh, do you think I need an MRI? And I'm like, it's not a first line, treat or screening for that. It is a degenerative process of a tendon. It's one of the tendons that pulls your wrist back. And for anyone who is out there, if you roll up your sleeve and you pull your wrist back, you will see the muscle that is moving in the upper part of your forearm. And that is the culprit as it attaches to that bump on the outer part. And often a little wrist splint or a counterforce base, those little bands. And if you are going to wear a band, that's where you place that pillow that comes with the band, right over that muscle that is moving. But if you were to
a little
get
bit below the pain area.
Right, exactly. Because if you put it on, it could exacerbate the symptoms. But if you were to get an MRI, you would see thickening, degenerative tearing of that tendon. And you'll see this in people 40s, 50s. You rarely see tennis elbow in someone in their 70s because by then, the tear usually completed itself and it burned out.
Yeah.
But in those people that don't,
self-healing.
Exactly. You can go in and debride those tendons.
Now, we wouldn't be doing justice if we didn't talk about baseball and baseball injuries and baseball season, since it is May 2021 and there is a baseball season, thankfully. So let's talk about kids. Let's talk about even like high school athletes. How to preserve their elbows, their shoulders to some degree, and some of those injuries, the Tommy John that everyone knows about. Yeah. How do we prevent this if it's preventable?
Right. So Tommy John surgery is a reconstructive procedure to restore the stability of the elbow. It is a tear of your ulnar collateral ligament, also known as the medial collateral ligament of the elbow. And it occurs in pitchers because when you are in those cocking phases, you're going to have what we call a valgus moment, and this will stretch out. Sometimes they can feel a pop, and that's an acute episode, but a lot of times they have the pain during those phases just because it chronically stretches out, and they no longer have that stability in the elbow. And prevention is the best way to address these issues. And it's become almost an epidemic and a pandemic in and of itself because when I was growing up, probably when you were growing up, we changed with the seasons and played different sports every season. Nowadays, adolescents are playing the same sport 12 months a year. And it doesn't give the body and those muscle groups the appropriate time to, heal.
So when you say prevention, so there's a couple of things with a lot of pitchers, right? There's biomechanics, their throwing style. Are they more a sidearm? Are they more over the head? Or is it more so that they're just doing too much too soon, too young in a lot of cases?
Right. I think a lot of times,
combination of all that.
In terms of too young, there are recommendations, about how many pitches and how many days they should pitch, how many days of rest based on how old they are. Okay. In terms of what pitches, those could be looked up on, the Little League websites. Major League Baseball also puts that out for the younger groups. But also in terms of the type of pitch. Now, you should not be thinking about throwing a curve, until you could shave. That's just a rough estimate because that's a sign of skeletal maturity because it just puts too much stress. So usually what we tell patients at the younger ages, work on your placement. You could throw your fastball, but don't start worrying about throwing a curve until you're just more skeletally mature. So pitch counts, days of rest. But it does get tricky, for coaches when the kid is in 2 or 3 different leagues. And those teams don't talk with each other.
Right, and the parents sometimes push the kids or just ignore the science or ignore the warning signs because they want to see the kid play, which unfortunately is probably a disservice to their own child.
So, I would recommend if you are going to play in a couple of leagues, don't pitch in all the leagues. You can be a pitcher in one, play second where there's, some lower throwing demands. Or, if you are going to play, just play different positions at different times so you don't overthrow.
Yeah.
But also...
Problem is that when he's a good pitcher, right?
Yes.
But we understand we have to protect the kids.
But there used to be an old saying, when you're looking at prospects and drafting players in the major leagues, you want to get pitchers from the north and hitters from the south. Because the pitchers that grew up in the south pitched all year long and had more propensity to overthrow and stretch out.
Right.
And the pitchers in the north, being that they had the winter, they didn't pitch 12 months a year, although that's changing now. They used to not have as many issues with the elbow when they got to the higher levels. So I personally think it's very important to change with the seasons. I think when you're younger, you still could get, to the next level if you're an excellent athlete, even if you're a two-sport athlete. Sometimes doing soccer, helps you with your basketball footwork.
Sure. Sure.
So, and you just cross-train and develop different muscle groups. But, back to baseball, not overthrowing is also based on proper mechanics. And you could probably attest to this as well. It's about strengthening your core, strengthening your legs.
Yes.
Because a lot of that initial torque comes from your body.
Absolutely. And if you look at any, not every pitcher, but a lot of pitchers, if you look at their body types, all of their strength is in their legs and lower torso. They're not necessarily have these huge, arms, or, you don't need that to be a pitcher. You need better mechanics. You need push off with your legs. That saves your elbow. That saves your shoulder, because you're using the rest of your body mechanically correctly. A good example might be like an Andy Pettit. The guy's, legs were probably like tree trunks, as were Roger Clemens, like all those guys that had longevity in the league. Now, granted, as they got older, they may have broken a couple of rules, to keep going. But for the most part, they were longevity type pitchers because they had that ability, that strength.
Right. And for, younger athletes, things that you need to look out for to make sure that you're not overthrowing your elbow is if you notice any change in your velocity or any change in your arm angle. So if your arm starts dropping down, those are signs that you may be getting some weakness or stretching out of that ligament. And, that's when you should, get evaluated and also shut down for a period of time. Shutting down early in the process could save the arm, versus if you try to power through it, then you may ultimately lead to something more invasive.
And now that we're talking about sports, just kind of crossed my mind.
Yeah.
Have you dealt with, or have you seen, or have you had to deal with maybe an adolescent or someone maybe in their 20s, maybe 30s, that are pushing themselves with performance-enhancing drugs, and then maybe in a way negatively affecting their body, whether it's a tendon issue, whether, we know that steroids have negative issues, and they could have more tendon problems, more other musculoskeletal problems that weren't expected as part of the strength process. So have you encountered that in your practice?
Thankfully, in the community that we live, I have not seen too much in the way of, performance-enhancing, drugs and the subsequent sequela. As I've up here, but in the city, sometimes if we see some more people like that are competitive bodybuilders,
yes,
that's where I've kind of seen those kind of things that can occur. And people, can get a distal biceps tendon rupture.
Yes.
You would think it's from their weightlifting, but sometimes it could be as a result of using, steroids.
Degeneration.
Right. In fact, when we see people with tendinitis conditions, one of the most common being something called a trigger finger. We treat these injuries or these overuse syndromes with steroid injections.
Sure.
But when I tell people, for a trigger finger, and what a trigger finger is, the tendons that bend our fingers, they run in a tunnel. And that tunnel is right here. And it starts as pain, but sometimes it can progress to the point where you bend your finger and then it clicks and gets stuck. And that's either because the entrance got swollen or the tendon got swollen. It's a size mismatch. And we give some steroid to decrease the swelling around the tendon so it can fit through better. But I tell patients we max out at 2 injections for that, because too many steroids can ultimately weaken the integrity of the tendon.
What causes a trigger finger? Is that hereditary, or can it be repetitive stress, or a combination of?
It usually is a repetitive stress injury. Okay. There are certain medical conditions that can predispose, such as diabetics, significant hypothyroidism, rheumatologic conditions. They have a higher incidence than the general population, but in and of itself, it's one of the most common hand conditions that's out there. But yeah, too many injections will weaken the integrity of the tendon. And just as another aside, each shot has less of a chance of being that long-term cure. So I usually max out at 2, just so that I do no harm, to the tendon.
Yeah, because steroids, and they do have a negative effect over if you too much in one area, especially in a small area with a smaller tendon,
right,
where the body doesn't have the ability to absorb it, and it has more of a direct effect on that tendon. But again, you don't want too much of it. So
Right.
now, was it TFL? Was that something we wanted to discuss? Is that
TFC injuries.
TFC?
Yes.
Yeah.
TFC injuries. This is a time of year where you start to see a lot of this as people get back onto the golf course. The TFC is kind of the equivalent of a meniscus in your knee. Its role is to be a shock absorber on the outer part of your wrist. And you can see a lot of these with torsional.
I just envisioned myself swinging that golf club, and I felt it just as you said it.
Yeah, and you'll see
Tells
this.
you the kind of golfer I am. But
You can see this a lot of times when you take just a fat shot, or you ground your club, you hit a tree root,
Been there.
and you get that jolt, and you just load this what we call the ulnar side of the wrist, and that's typically you'll have more pain when your palm is down and you forcefully only deviate, and that would be a provocative maneuver to elicit that response. Sometimes when you are going back with your club, your wrist will be extended, and you'll deviate, and you could have injuries to what's called the ECU tendon subsheath. And that would be more of a snapping sensation, more as you twist palm up, versus the TFC would be more elicited with palm down and deviation. Most TFC injuries can get better with time. It serves two functions. It's a shock absorber, and then it's a stabilizer between your radius and your ulna. So the ones that need acute intervention are when you come in and this has popped and you have instability. That requires a surgical repair. But for the ones where you've lost kind of that inner bounce or trampoline effect, those often rest, maybe an injection, maybe some therapy to strengthen some of the surrounding tendons to unload that area could be quite effective. But yeah, this is now the time that we see that with all the golfing injuries. Other kind of injuries that we see at this time of year with golf, tennis, other racket sports, baseball starting to come, is a traumatic injury called the hook of the Hemi. And that occurs because anything with a club, a racket, bat, when you are swinging, that could shear off this bony prominence that's right down here in the palm. And often that does not heal. And the best route of treatment for that is just removing that hook of Hemi. So if you are a golfer, tennis player, baseball player, and you start having pain in this area of your hand, that would be recommended to come in and get evaluated with x-rays or sometimes an MRI to see if you have a hook of hamate fracture. If left untreated, the tendons that bend your ring and your small finger could rub across that non-healing fracture site, and those could snap. So you want to address that early if possible.
all right, great. So we really talked about a bunch of different things. I mean, you wouldn't think for like such a small part of your body, but a very important part of your body.
Yeah, absolutely.
So many different things can go wrong. Various sports injuries, various ergonomic injuries. I believe that obviously being a specialist in elbow down situation. When you do surgeries, I know like a lot of times you'll work with like what they call a certified hand therapist. Very
Yes.
important because people have to understand that the intricacies of these ligaments are very tiny, very, very fragile to some degree. So if you do a procedure to correct something, it's very important that they go slow. Physical therapists can do certified hand therapy as well as an OT.
Yes.
But that specialty is important because the bracing sometimes is critical to the outcome of what you're doing.
Yeah, absolutely. Hand therapists are often OT, but they can go the PT route as well, just like hand surgeons are often orthopedists, but could come from the plastic surgery route. And the hand therapists are very important in terms of making, the custom splints. Very important, as you said, when we do, particularly the tendon repairs in the hand, and then also when we do nerve repairs in the hand. A lot of the elbow stuff, I think there's a lot of crossover with the physical therapists as well. So I'll use physical therapists for a bunch of the elbow things, that I do.
Sure.
Now I think therapists have also done some, video or telehealth, for patients as well. Obviously, the more hands-on, needing the splints, and that is not as easily done. But sometimes if it's just about learning range of motion exercises, or what we call nerve gliding exercise to stimulate blood flow around the nerves, those could often be done maybe one session in person and then follow-up visits just to make sure that the patient is understanding the appropriate way to do it via telehealth as well.
Yeah, telehealth has been very interesting this year. As physical therapy and chiropractic and acupuncture, I mean, there's certain things that we haven't been able to do telemedicine-wise, but there are a lot of things you can do. Yes. Evaluation, and for us, there's such a manual component, just like you can't operate through the internet, right? So, so just like we can't do our manual work, which is a big part of how we get people better. So, but it's been surely technology has been driven this year, and it's helped medicine in some capacity. And actually, I was thinking about, maybe we should start a mobile X-ray unit if that's what's needed. Send an X-ray right to the parent, just so they don't have to go to a facility. But most of the facilities were able to stay open. Critical healthcare stayed in place. We were fortunate, I think, overall. People should, even though we had a lot of political imbalance and a lot of different things, I think, our healthcare system did a good job. So tribute to people like yourself and to your hospital and to all of the essential workers out there. I think it's been a tough year, but I think we did pretty well as a society. So
absolutely, and I'm looking forward to normalcy. I think we're almost there.
Yes.
I got vaccinated. I believe you got as well.
Yeah, and everyone seems to be doing pretty well.
So I think that's important. For us to return now. Hopefully, they've extended it to 12 to 15-year-olds that they can get and have normal school years.
Yeah, and with the kids playing more sports, I think hopefully that'll be important. We'll get that done. So anyway, I want to thank you again for being here for a return visit. I think you might be the first return visit, so that's great. And we will catch up hopefully down the road. So
happy to come anytime.
Thank you again for watching Health IQ. I'm Alan Siegel. We'll see you at the next show. Thank you. Good night.
All right.